Good day. On behalf of the Chronic Liver Disease Foundation, I'd like to thank you for joining our webinar entitled Implications of NAFLD in Persons with HIV. I am your host, Jerry Mayberry. Today's webinar is funded by Echosens North America, the inventors, manufacturers, and distributors of the FibroScan technology. This presentation includes information on the uses of the FibroScan technology from published literature. Echosens does not intend to make any specific claims found in this presentation. The FibroScan is FDA cleared as an aid to the diagnosis and monitoring of patients with chronic liver disease as a part of the overall assessment of liver health, and it is not intended for the treatment of any specific liver disease or condition. Before I introduce today's speaker, please be aware that all participants are muted to sustain sound quality during the event. If you have a question, please type it into the questions panel on your computer screen. When we enter the question and answer period, all questions will be read to Dr. Sulkowski for his response. We apologize in advance if we do not have time to get to all posted questions. Now I wish to introduce today's speaker, Dr. Mark Sulkowski, Director of the Viral Hepatitis Center at the Johns Hopkins University School of Medicine. Dr. Sulkowski.
Hello and welcome. I'm Dr. Mark Sulkowski from the Johns Hopkins University School of Medicine. Today we're going to discuss non-alcoholic fatty liver disease in persons with HIV infection. This is increasingly a problem among this population, and as we'll discuss, a major problem among the U.S. population in general. We're paying more attention to fatty liver disease in the context of curative hepatitis C treatments and, of course, better HIV disease outcomes. So today we'll try to discuss the epidemiology, pathogenesis, the evaluation, and a little bit about management of this condition. This figure highlights the idea that liver disease is common among people with HIV infection. Now, you'll see on this slide that there are some historical diseases, such as opportunistic infections. It's perhaps hard to remember at this juncture, but there were OIs that did directly involve the liver, but we don't see those much any longer. This slide also depicts viral hepatitis A, B, and C, which of course remain important pathogens and should be evaluated and treated. But in general, we have therapies for B and curative treatments for C, and hepatitis A is vaccine preventable. You'll also see in this slide alcohol. I'll come back to this point because I think we have to be very careful not to underestimate the impact of alcohol in this population. And of course, today we're talking about non-alcoholic fatty liver disease, but of course alcohol is a major cause of liver disease in persons with and without HIV. Now we'll talk a little bit about antiretroviral therapy. It seems the liver and perhaps NAFLD is a part of HIV treatment, and we'll come back to that point. Now on this slide, fatty liver disease is also depicted. We think this is a common problem. We'll talk about some of the studies demonstrating the prevalence, but we know that this patient population has high risk of diabetes, dyslipidemia, and increasingly we're seeing obesity and weight gain playing a role in this patient group. And we are seeing that fatty liver disease is increasingly being recognized, particularly in persons without hepatitis B or C or in those with cured hepatitis C. Well, if we look at the most common measure of liver damage in people with HIV, that is liver enzyme elevation, there was an interesting study presented at the recent CROI meeting using the ACTG cohort known as HALO. Now, in this study, the investigators wanted to look at how often liver tests were abnormal in people who did not have a history of heavy alcohol use, who did not have hepatitis C or hepatitis B. They looked at ALT levels that were greater than 30 for men and 19 for women. So if we look in the upper left-hand corner of this figure, we see that only 31% of individuals had no elevations during the study follow-up period. In fact, most individuals had abnormal liver enzyme tests, which is really quite remarkable but not surprising, particularly for those of you who see patients in this population. So what's interesting about this study is then we looked at factors that were associated with having abnormal liver enzyme tests. And we see is when we include parameters like the hepatic steatosis index, which includes things like BMI and diabetes, and we see there is a risk of having liver enzyme tests that is linked to both the metabolic syndrome or the hepatic steatosis index, and really seems to be linked in part to fatty liver disease. Now, it's important to note this study did not perform liver biopsies. What we see here is a strong association of elevated liver enzymes in people with HIV and parameters linked to the metabolic syndrome. We also see parameters like albumin that are high that is thought to be a measure of overall health and perhaps correlates with BMI. So if we move to another measure of liver disease, that's end-stage liver disease, really the gold standard, if you will, people dying of complications. This was an interesting study published several years ago that looked at the incidence of ESLD in this population in three different eras. This is the early ART era, the middle ART, and the modern ART era. And there's a couple of groups. There's people with Hep C only, Hep B only, and both viral hepatitis groups. And generally what you see is that this group of patients really has not had much of a change in terms of the incidence of ESLD, although you start to see a trend down in the people with hepatitis B in this era, although there's really no clear reduction in ESLD. But I wanted to also focus on this group of people without Hep B and Hep C. And although the incidence is lower than those with viral hepatitis, there is a consistent incidence of liver failure occurring in this population. And some people think this may actually start to increase, particularly as we see more fatty liver disease occurring in this patient population. Another study that's quite important, recently published in Lancet HIV, looked at the population attributable fractions for ESLD in two patient groups. There was a large cohort of 35 individuals where all factors were considered, and then a group with at-risk alcohol use. So this looked at a large number of individuals with validated outcomes, and it attempted to measure the proportion of the risk of liver failure that was due to a particular disease. Now, in this cohort study, it's clear that liver disease, the greatest population attributable fraction, was due to hepatitis C, about 33%. But we also see evidence of a link to hepatitis B and to alcohol use. This study was really not able to tease out non-alcoholic fatty liver disease, in part because that's not something that's routinely measured and captured in databases like this one, and in part because to date the impact of fatty liver disease on outcomes such as ESLD may be morphed by that of viral hepatitis C. But of course, we're curing more people with hepatitis C and expect to see greater risk. I also wanted to mention this study because I don't want to underestimate the impact of alcohol in this group. There is both alcohol we are aware of in our clinical practices, but of course, as many of you know, we don't often ascertain alcohol risk as well as we should. So as we talk about NAFLD, let's not forget about alcohol. Now, this study looked at the causes of death in people in the ART era. And I highlight this to mention that the number 3 cause of death in this cohort remained liver disease. And this is certainly an important problem. You'll see also cardiovascular disease is about 10%. When we think about fatty liver disease, it's also important to note that many of the same factors that cause fatty liver disease, that's obesity, diabetes, dyslipidemia are also strongly related to cardiovascular outcomes. In fact, there are a number of studies that suggest liver fat or steatosis is a marker of risk for cardiovascular disease, and in some studies it's independent risk. So there is this intersection of fatty liver disease and cardiovascular disease in this patient population, and indeed we can think about fatty liver disease as the metabolic outcome for this organ. I mentioned alcohol a couple of times. As we look at studies of non-alcoholic fatty liver disease, I did want to highlight how clinical trials in this disease state define alcohol. It's 21 standard drinks per week for men and 14 standard drinks per week for women. And if people are below these thresholds, then the alcohol is not thought to be the major driver of steatohepatitis. I did want to point out that in a number of studies, though, it does appear that alcohol is contributing or overlapping with non-alcohol steatohepatitis. And in general, it's important to think about these alcohols contributing to some people. Now, a standard drink is depicted in the figure here, and my advice to individuals with evidence of fatty liver on non-invasive testing is that they avoid all alcohol. There are some studies, as I mentioned, that increasingly show these may act to worsen non-alcoholic fatty liver disease. Let's now turn to talk about what's known as NAFLD in more detail. So as I mentioned, this is the hepatic manifestation of the metabolic syndrome. And NAFLD is really a spectrum of diseases. It runs from simple steatosis, often called NAFLD, to non-alcoholic steatohepatitis, which is what we refer to as NASH. So NAFLD is where on liver histology there is fat involving more than 5% of the observed hepatocytes, but without evidence of hepatocellular injury or ballooning. NASH is defined as having steatosis in more than 5% of hepatocytes, plus inflammation with hepatocyte injury, with or without fibrosis. Now, the prevalence of NASH in populations of people with evidence of fat on a non-invasive test, say ultrasound or liver elastography, if they had an indication for the biopsy, that is, that's an abnormal ALT test, the prevalence of NASH was 59%. But if there's no clinical indication, they just saw fat on a non-invasive test, it was lower, as one would expect, about 6%. But you can see that a subset of individuals with steatosis seen on imaging or non-invasive testing do have significant NASH or steatohepatitis. The importance of this is really important in terms of clinical outcomes. Now, I've mentioned liver biopsy in the previous definitions, and I will say that as we've moved away from liver biopsy in people with viral hepatitis B and C, the criteria for NAFLD scoring are shown here. And in clinical trials being done today, this is still, that is, biopsy used to evaluate patients. So pathologists look at steatosis, lobular inflammation, ballooning hepatocytes, and fibrosis, and have a definite borderline or no steatosis based on this scoring system. We'll come back to this as we look at some clinical trials. Now, there is a role for liver biopsy and evaluation of patients, but as we'll discuss, non-invasive testing is really takes the major role in clinical management, and patients entering trials are the ones that largely get liver biopsies. What is the pathogenesis of fatty liver disease? And we'll talk about this in some detail, but certainly it's thought of as a two-hit process. First, there is increased delivery of free fatty acids to the liver and this accumulation of triglycerides or liver fat inside the cell. This is where obesity insulin resistance and diabetes play a major role. And that's that simple NAFLD or steatosis in the hepatocytes. But it's really the second hit with this inflammation, thought to be due in part from oxidative stress and perhaps other inflammatory markers that may occur in the context of obesity. Now, this second hit, or hepatic inflammation, is what's thought to drive fibrosis and disease progression. This slide shows the natural history, if you will, of individuals with NAFLD. So it's thought that many patients with simple steatosis, or NAFLD, will remain stable. And it's important to keep in mind that these patients almost certainly have problems with respect to cardiovascular disease risk and other outcomes and need careful attention. But it's these individuals with NASH, that is hepatic inflammation, that are at risk to progress to cirrhosis. And once cirrhosis develops, a very high risk of hepatocellular carcinoma and liver failure. So this is certainly something to be concerned about. There is also the recognition that steatosis or NASH may lead to hepatocellular carcinoma in the absence of cirrhosis, which is something we don't typically see in the context of hepatitis C. So there is a feeling that this group is at increased risk for hepatocellular carcinoma, and in the future may be most of the cases we see. In fact, in a study by Wong and colleagues in 2015, looked at the reasons why people were being listed for liver transplant in the United States. Now, there's some good news here in that the number of people being listed for transplant due to hepatitis C really is starting to fall in this study and in the current era, 2019 and beyond. But NASH had the greatest increase as a cause of people being listed for liver transplant, that is, joining the wait list, the 170% increase. And as you can see, it's, at the time of this study, become the second leading indication for liver transplant. Now, there's also been a simultaneous increase in alcohol liver disease, depicted on this slide as ALD. And indeed, alcohol is also increasing in the United States as a reason for listing. And there may, of course, be some overlap in these two conditions. People living with HIV. And there's a couple of studies that have looked at this and summarized some of the data. This was a very nice paper by Verna and colleagues in Lancet Gastroenterology Hepatology in 2017 that looked at a number of studies that evaluated the prevalence of NAFLD in people with HIV in the modern art era. I'll come back to why the modern art era is important compared to the early art, but in general, we saw fatty liver disease due to D4T and DDI, and when we look at more modern eras, we're removing those. So a couple things to point out. It is important to look at the patient population. You'll see that some of these did include people with HIV Hep C, and some focused on those with HIV alone, excluding Hep C, Hep B, and alcohol. The numbers of patients range from 500 to as small as 14 where biopsies were done, which leads me to the next point of how the fatty liver was evaluated. Liver biopsy was done in some of these studies, but increasingly we're seeing large studies with transient elastography with CAP assessment or controlled attenuation parameter that we'll come back to, but provides a validated assessment of liver fat in a non-invasive manner. So if we look at the prevalence of NAFLD in patients with HIV monoinfection, we see it ranges, but many of these studies show it to be in the 35 to 40% range. And I'll come back to these points, but if we look at predictors of NAFLD, we're seeing things like insulin resistance, high BMI, large waist circumference. In other words, the metabolic factors are playing a major role in the pathogenesis of this population. The next study to focus on is a meta-analysis systematic review that was conducted and published in AIDS. A nice study looked at 410 studies overall, and 10 were included. The studies of the NAFLD prevalence was really based on imaging studies and had a pooled estimate shown in the figure of about 35%. Now, so that would suggest that about a third of patients has some evidence of fat on evaluation. And then the NASH prevalence was evaluated in 208 patients and studies that had liver histology, and those are shown here as well. Of those selected for liver biopsy, 41% or 41.7% had evidence of fatty liver disease that also included NASH or steatohepatitis. So these individuals are at high risk for progression to cirrhosis and hepatocellular carcinoma. They have major risk of liver disease. Now, I mentioned pathogenesis a bit earlier, but this slide is a nice figure from the same review by Verna, and it includes the metabolic syndrome that I talked about earlier. It includes things like dysbiosis, bacterial translocation. It is important to think about how gut affects the HIV affects the gut mucosa and may lead to more translocation. But in the pre-modern ART era, we saw that mitochondrial injury due to DDI D4T, that is antiretroviral therapy, played a big role. In the modern ART era, as we'll discuss, obesity, insulin resistance, low physical activity are driving this disease, and the role of HIV itself is under some discussion. I'm going to come back to that in some more detail. But there is evidence that HIV treatment may still be playing a role, but perhaps not through this mitochondrial injury. So let's first dig into the relationship of fatty liver and metabolic disease in this population. A very nice study that was included in some of the reviews I talked about earlier, Morse and colleagues at the NIH looked at people who had elevated AST or ALT, no chronic hepatitis, and on a workup had no evidence of other causes. They had a liver biopsy and a detailed evaluation. Of these patients, 73% had NAFLD, 55% had NASH, and about 20% had evidence of bridging fibrosis or advanced liver disease, suggesting that they were at risk for complications. In terms of risk factors, they found insulin resistance, obesity, and a genetic factor that's been identified, PNPLA3 gene, were associated with increased risk in NASH. Now, in this analysis, they did not see an association of fibrosis and any specific HIV drug or the patient's treatment with antiretroviral therapy. So they really saw this link, genetic factors plus insulin resistance and obesity. If we then switch back to the systematic review meta-analysis by Maurice and colleagues, they gave a very nice evaluation of the meta-analysis for risk factors. And if we look at these in sequence, we see really no association of NAFLD and age. As one might expect, waist circumference favored the presence of NAFLD, as did hypertension. BMI, diabetes, and triglycerides all were associated with the presence of steatosis or NAFLD on evaluation. If we continue to look at some other markers, the link to cholesterol and LDL was also there. Fasting glucose also present. Now, I also wanted to focus on ALT and AST measurements. I mentioned this early on with the study from Chu and colleagues, the ACTG. Here, people with fatty liver disease were more likely to have an elevated ALT as well, and that goes hand in hand. I'll come back to this point, but an elevated ALT in persons with HIV is not normal. That's not a healthy parameter, and we need to be concerned about those patients. But let's turn now to look at the relationship of NAFLD and HIV disease and treatment. If we back to this meta-analysis, here the link is found with higher CD4 cell count, perhaps a marker of someone who's getting healthy and is doing well in antiretroviral therapy. But the link to duration of heart actually went the opposite direction. Being on HIV treatment tended to lower the risk of having fatty liver disease in this study, and suppressed viral load, the association was also not quite as strong. So here, it looks like in this meta-analysis, systematic review, it's metabolic parameters. Now, I mentioned this a bit earlier, but in early studies, and this was a study we conducted at Johns Hopkins in the early 2000s. Now, we were here really looking at the early ART era, and we looked at patients with HIV Hep C who had a liver biopsy, and we graded the steatosis by how many hepatocytes contain fat, none to grade 4, which is more than 60% of hepatocytes. And you see that 60% had no fat, but 40% had some fat, and NAFLD greater than 5% presence in about 20%. In a multivariate model, we saw the presence of fat in this early ART period was linked to Caucasian race, weight greater than 86 kilograms, hyperglycemia, and the use of stavudine, which of course was a drug that was known to cause mitochondrial toxicity. When we looked at the ART association, we saw a linkage between individuals who were receiving protease inhibitors as well as stavudine. So that was the early look at this population. Well, we jumped ahead and looked at people who had 2 liver biopsies. And we wanted to know, of those who had fat, how many were stable, how many got better, how many had worsening, and of those with no fat, how many gained fat. So we had 222 people with at least 2 biopsies. They all had Hep C as well as HIV, and the median time was 2.82 years between biopsy 1 and 2. We saw that among those with significant fat, a number, about 60%, actually had a decrease, and about 10% increased the amount of fat. We did see that 13% of our patients went from no or trivial fat to significant fat. Now, in this model, we saw that Caucasian race was associated with a more progression. Antiretroviral therapy also lower progression. CD4 count greater than 350 progression. The biggest predictor of who had no fat and gained fat was BMI at biopsy 1. So we saw people who with a BMI above 30 and a BMI above 30 progressing in this patient population to have fat. So obesity was driving it. But are HIV drugs really off the hook? In the study I just mentioned, we didn't see a link to antiretroviral therapy. But in a study published from Spain, that was a randomized trial. They took 47 people. They all had fatty liver disease using liver elastography or FibroScan and a CAP score of greater than 238. That roughly correlates with 10% of hepatocytes containing steatosis. They randomized these people with NAFLD to raltegravir or efavirenz, and they looked at what happened to the fat. And in the figure, you can see that people who were randomized to raltegravir had a decrease in hepatic steatosis when seen on liver elastography. Those randomized to efavirenz had an increase in liver steatosis, and this is shown in both the change as well as the absolute scores. So in this study, it looks like being switched to raltegravir over a period of 48 weeks actually decreased liver fat when compared to being randomized to efavirenz. So if one just looked at this 48-week time point, perhaps one might conclude that this class of medications, integrase strand transfer inhibitors, was less likely to lead to fat accumulation. But this is still an ongoing story. Story that was featured certainly at the CROI meeting in 2019. And here, several studies focused on weight gain, which has been associated with integrase strand transfer inhibitors. Now, these are the drugs that are recommended to use in people living with HIV. In the first study, they looked at the 5-year weight gain in 24,000 people starting antiretroviral therapy. and saw the people starting integrase inhibitors had a 6 kilogram compared to only 4.3. So this group is gaining weight. In a similar study that looked at people before and after a switch to integrase strand inhibitor, we also saw a weight gain here in the period of time after switching to these. So we know weight gain is linked to fatty liver, so this might imply we'll see more fatty liver disease, and the jury is still out here. We just simply don't have enough information to comment on that. Does bring me to the point that was made in a plenary session at CROI that obesity and HIV is a major problem. The figure to the left depicts the prevalence of HIV in the U.S. and the prevalence of obesity. While the prevalence of HIV has been relatively stable, you see it's concentrated in the southeastern United States, and obesity is actually increasing dramatically. And it is also concentrated in the southeastern United States, although obesity is increasing really in many parts of the United States. So we're seeing sort of the overlap of two epidemics. And when one looks at people living with HIV, it's important to consider both HIV disease and antiretroviral drugs, things like microbial translocation and inflammation, adipose distribution, but also things like diet, food insecurity, access to healthy foods, activity, exercise, other factors, host factors also play a role, including sex, race, ethnicity, alcohol, mental health, things like depression. So there are a lot of factors here that are impacting this obesity epidemic that we're seeing not only in the United States, but also in our patients with HIV. And this is one of the reasons why there's a growing concern we're going to see more fatty liver disease and more complications of fatty liver disease in people living with HIV. So I've mentioned evaluation a couple of times and want to come back to that. This study just published in JADES by a French group of investigators. They looked at a European cohort, and they had 402 patients with HIV at risk for NAFLD who had a screening test, either a blood test or a liver elastography or fibroscan. They had 140 individuals who by fibroscan had a liver stiffness of greater than 7.1, and these individuals were recommended for liver biopsy. Now, I've mentioned a couple of times that liver biopsy is still considered to be a major driver, if you will, of this patient population in terms of how we diagnose them. 64% refused liver biopsy and 49% had a biopsy. They looked at the area under the receiver operating curve for non-invasive tests for steatosis. They used the controlled attenuation parameter. This is derived while performing a liver elastography or fibroscan, and it's based on an ultrasonic signal that quantifies the attenuation of the wave during the procedure. They also looked at a commercially available test from Biopredictive, known as steatosis, and MRI-PDFF. MRI-PDFF is a test that measures the protein density fat fraction and is very good. As we look at the correlations here in the figure, we see the fat fraction of MRI had the highest area under the receiver operating curve, and CAP score was next at 87 and performed better than the serum commercial test, the Steato test. So this suggests that the CAP score, which is being used widely because, of course, elastography is non-invasive and less expensive than things like MRI-PDFF. So this, I think, is an important confirmation that in HIV-infected persons, there is a high correlation between fat seen on biopsy and seen on the elastography evaluation by fibroscan. Let me move to talk about some clinical implications. All persons with an elevated ALT level should be evaluated. I think this is something that we just don't do as often as we should in this population. We really need to recognize that an abnormal ALT is just that. It's not normal. It means we need to work it up. Tests for viral hepatitis B and C vaccinate against A and B if needed, and examine alcohol use. And I would recommend that we think about things like more standardized tests like audits and more detailed discussions of alcohol use. I think this is a factor in our patient population. We also need to look at metabolic parameters, weight and weight change, diabetes, hyperlipidemia, and then all these patients with an elevated ALT should have a non-invasive test. We routinely calculate the APRI or FIB4, which uses blood tests, ALT, AST, and platelet count. No reason not to calculate these. These are helpful tests that can give us some indication of underlying liver disease. And increasingly, we're using liver elastography, which assesses both fibrosis, which correlates with liver stiffness, as well as the CAP score, which, as we've discussed, correlates with fatty liver disease or steatosis. And then we can use this to think about which patients may benefit from a liver biopsy. Those with a high CAP score and fibrosis may benefit from biopsy, although if we think about it, we're going to recommend the same things right now, which is weight loss as opposed to FDA-approved treatments. So perhaps we don't need a biopsy here. We just need to treat that person or manage their NAFLD. I created a slide of how the interpretation we use in the Johns Hopkins HIV specialty practice. In general, after performing liver elastography, we provide the following guidance to our clinicians for liver stiffness interpretation, that it's the less than 8 is no or minimal fibrosis, and greater than 12.5 is fibrosis or cirrhosis. We use this, of course, for all liver disease and would apply to NAFLD as well. We also provide the following interpretation of controlled attenuation parameter. There is some debate about this, and it's been assessed in a number of different populations. But in general, the CAP score correlates with the liver steatosis grade. And in our population, we're defining less than 215 as healthy, 215 to 300 as moderate steatosis, between 10 and 66% of the hepatocytes, and greater than 300 to be severe steatosis, where more than 66% of hepatocytes contain lipid droplets. So this is the guidance that we use to provide clinicians with the indication. Now, this won't distinguish whether the steatosis is due to alcohol or non-alcoholic fatty liver disease. That has to come from one's clinical assessment. So the management of persons found to have NAFLD and HIV. As I mentioned earlier, I advise the avoidance of all alcohol. I think that abstinence makes the most sense here. Some clinicians will allow alcohol use, but I think it's better to abstain. And then the focus is on weight loss, including the consideration of bariatric surgery and a formal evaluation of lifestyle modifications. The goal is a 10% weight loss, and exercise may help independently. This figure is taken from a study of weight loss and shows resolution of steatohepatitis in patients who lost about 10% of body weight, and that's where that 10% number comes from. It's also important to manage diabetes aggressively, and statins are safe, but there's limited evidence they'll actually help people with fatty liver disease. And finally, consider vitamin E, and that's based on the Prevalence study. Prevalence was an RCT that was published in the Journal of Medicine and used 800 milligrams a day of vitamin E and randomized 247 adults to receive vitamin E, pioglitazone, or a placebo. And as the table shows, about 43% of the people on vitamin E had improvements compared to only 19% on placebo. There was also improvement with pioglitazone, but there was also weight gain with this agent, and really from this study emerged vitamin E may have a role. But it's important to note there are no FDA-approved medications at this time. There is, however, as depicted on this slide, a very robust pipeline of medications and therapeutic targets in development. A number of these are in phase 3 clinical trials, including cetracrivirac, which is also active against HIV through its inhibition of CCR2 and CCR5 and may actually slow fibrosis progression. There are other drugs here that may have a role, including FXR agonists, including beta-cholic acid, and PPAR gamma alpha drugs that may also improve fatty liver disease as well. We'll have to wait and see how these drugs perform in clinical trials. It's not clear yet that they'll be efficacious. In fact, some have been shown not to work in clinical trials to date. So this is an area where we have to watch and see for the targets of drug development. And I will point out these have not been evaluated at this juncture in people with HIV. There are, of course, keen interest in testing these drugs, but we'll need to pay attention to drug interactions as well as safety in this population. So stay tuned to the therapeutic advances in NAFLD, but the goal at this point in time is to focus on type 2 diabetes, dyslipidemia, and obesity, the factors in the lower left-hand corner of this slide. To summarize HIV and NAFLD, liver enzyme elevations are common in people with HIV, even after one removes viral hepatitis. Current evidence suggests that fatty liver disease is likely the most common cause of elevated liver enzymes in people without viral hepatitis. Alcohol may play a significant role. HIV and its treatment may also have a role. I think one of the stories we'll keep an eye on is the relationship of integrase strand transfer inhibitors and weight gain. It's too soon to make conclusions about this relationship, but we do know that weight gain is a major driver in terms of obesity and fatty liver disease. I want to reemphasize the point that all persons with ALT elevation should be evaluated, and we use a combination of non-invasive tests, APRI, FIB4, and liver elastography, and some will consider biopsy. And as far as management, there's no question that weight loss is the key treatment. That's going to benefit the patient with respect to their liver, their cardiovascular disease, their diabetes risk, their hypertension. It is an important goal in the management of people living with HIV to focus on weight loss. There are drugs in development. Stay tuned and to see which one of these emerge as efficacious for the treatment of fatty liver. So thanks for your attention.
Thank you, Dr. Sulkowski, for that informative presentation. We've been monitoring the participant questions during your presentation, and we will now read them for your response. I wish to remind all participants that they can still enter new questions in the questions panel of their computer to get them in the queue to be presented to Dr. Sulkowski. I now wish to introduce my Ecosens colleague, Remco Inserink, our Director of Strategic Development, who will now read the questions to Dr. Sulkowski. Remco.
Thank you, Jerry. Thank you, Dr. Sulkowski, for an excellent presentation. I have a couple of questions that I try to group per topic. So let's start with HIV as a risk factor for NAFLD and end-stage liver disease. I think you showed a lot of interesting data, particularly around populations with HIV, with or without NAFLD. And so this question basically is twofold and relates to HIV as a risk factor for NAFLD. And the question is, are you aware of studies assessing the prevalence of NAFLD in patients with HIV compared to a control group of patients without HIV? And if so, has it been shown conclusively that the prevalence of NAFLD and end-stage liver disease is increased in the HIV group compared to the non-HIV group?
Well, that's a great and complex question, so thank you for that. What I would say is that we are still very much learning about fatty liver disease in HIV-infected persons. There is data to suggest that the prevalence is higher in people with HIV compared to those without HIV, and there's also data based on longitudinal liver elastography with CAP measurement that it may progress more quickly as well. And there are some biologic reasons why we think HIV may impact. One is that one of the very early events in HIV infection is a disruption of the gut mucosa, and there may be a role of microbial translocation that's greater in the setting of HIV even after treatment. And then, of course, there's the HIV treatment itself. As we discussed, some of the older nucleotide analog reverse transcriptase inhibitors had an effect on steatosis, and now we're seeing a pattern of weight gain related to integrase inhibitors that's still being sorted out. So I think the short answer is yes. The long answer is more research is needed.
Excellent, thank you. And that actually, I think, answers the second question, but I'll let you be the judge of that. So the second question related to this was, if the prevalence of NAFLD is indeed higher in patients with HIV compared to patients without, what do you speculate are the specific factors driving NAFLD beyond medication use? So I think you talked about gut mucosa dysregulation, correct? Anything else that pops?
Well, the other interesting facet is when we look at inflammation, there's clear evidence that HIV infection, even following treatment with antiretroviral therapy that can be highly effective over many years, is associated with higher markers of systemic inflammation and potentially intrahepatic inflammation. And I think one of the key elements here is this transition from simple steatosis or NAFLD to NASH. And I think given this inflammatory environment, there is concern that we may see more patients with NAFLD progress to a steatohepatitis leading to fibrosis and complications. I think the other issue that is important is we're really just beginning to look at this. I mentioned a study that shows a very high proportion of persons living with HIV, no Hep C, no Hep B, no alcohol, have a high prevalence of abnormal liver enzyme tests. It really does beg the question, is that fatty liver and is that NASH? So I suspect over the next couple of years we'll have more answers.
Okay, and that brings me basically to the second topic then, as you touched on the elevated liver enzyme. So specifically, when it comes to elevated ALT, I think you mentioned during the presentation that we should be concerned for patients with HIV that are displaying elevated ALT. And so the question was, should ALT as a risk factor for NAFLD be interpreted differently in HIV-infected individuals compared to just normal non-NAFLD patients that are not HIV-infected?
Well, I would say just the primary issue is that an abnormal ALT is not normal. And what we often see in our clinical practice is this, what I describe as a sense of normalcy assigned to an ALT that's modestly elevated. In other words, they don't get worked up perhaps the way they should. And I think that anytime the liver enzymes ALT and AST are elevated, that should prompt a thorough workup, serologies and potentially nucleic acid testing for viral hepatitis, an assessment of alcohol, and I think a screening test for fatty liver using things like ultrasound and liver elastography or FibroScan.
Okay, so related question to elevated ALT, do you believe that ALT has adequate sensitivity to serve as a pre-screen test to determine what patient would benefit from further workup?
Well, I think that also gets into a question that actually came up in the study looking at the prevalence of elevated liver enzymes. There's a lot of debate about what a normal ALT threshold should be, but I think that what we have to also look at is the context of the patient. So I am struck by the studies that support a 30 for men and a level around 19 or 20 for women as the true normal level. So the other piece, though, to it is what are the patient's risk factors? Is there obesity, cardiovascular disease, type 2 diabetes, hyperlipidemia, especially triglyceridemia? Are there medications? And in that context, one really should be thinking about the liver as the the metabolic complication of these other conditions. So I think casting a broad net makes a lot of sense, and remembering that a normal ALT is not the lab reference range, which may be as high as 45 or in some labs 60.
Okay, thank you. So some questions, further questions are coming in. Question from Gab Teferi. Is the management of NAFLD different for HIV patients than for non-HIV patients?
Well, that I think is a really great question. I mentioned the study with vitamin E. As of right now, there are several studies ongoing with vitamin E for fatty liver, at least one study I'm aware of. But we don't have conclusive evidence that vitamin E, given at the doses and duration studied in the Prevalence trial, would have the same effect, yet that's what many of us are using. I think the management with respect to weight loss, I do think the evidence suggests that weight loss will benefit this group as well as others, but again, it hasn't been well studied. And the other point I want to make is that although we have a number of exciting therapeutic strategies in development, the number of these entities, these drug entities that have been studying HIV is relatively small, and we don't yet know how they'll perform in this population. So I think the short answer is yes, the management is the same, focus on weight loss through a combination of reduced calorie intake and exercise, potentially even bariatric surgery, as well as the use of vitamin E, understanding that we don't have specific data.
Understood. Okay, thank you. So moving on more to HIV screening, and we already talked a little bit about using ALT in that sense. In your view, should all HIV patients with primary risk factors of obesity and type 2 diabetes be referred to for further non-invasive fibrosis and steatosis level screening?
Well, I think we're really just getting started with this idea of looking more broadly at the HIV population. So as we look at people who are aging with HIV and people living with HIV for over long periods of time, we've been focused and heavily focused on viral hepatitis C. We're focused on hepatitis B, which remains a problem. And we've tended to ignore the other, what I would describe as two major liver problems, which is alcohol and non-alcohol associated fatty liver disease. So in that sense, I think there is an argument to be made for both evaluating the liver through serum ALT and AST levels, but also having a low threshold for non-invasive evaluation with elastography and CAP.
Okay. Another question, and I believe part of this might have been addressed in your presentation, but I'm going to ask it anyway. Does current ART have any impact on the development/severity of NAFLD/NASH in patients with HIV? And are there any specific ART regimens that should be preferred in the presence of NAFLD/NASH specifically?
Yeah, it's actually a great question and one without clear-cut answers, and it's a bit complicated. So we think that well, let me back up. The Department of Health and Human Services antiretroviral guidelines recommend the use of integrase strand transfer inhibitors, integrase inhibitors, in combination with nucleotide analogs. We believe that the current nuke backbone, which generally consists of abacavir, 3-TC, or tenofovir, FTC, is not likely to lead to mitochondrial injury and steatosis. We haven't seen that over decades of use. And up until recently, we thought the integrase inhibitors were beneficial. Indeed, there's a study published showing that the CAP score went down. But now there's this question about what to do with the weight gain that's being observed, and is it really different with this class of drugs, which is otherwise a fantastic addition to the HIV armamentarium? And I would say at this point in time, I think that we don't have conclusive evidence that the recommended regimens are linked to fatty liver, and I would continue to support those regimens as first-line therapy based on a plethora of data showing their safety, tolerability, and efficacy. That said, I can tell you that there will be more data coming as a number of investigators are looking at this question about this class and about weight gain. But as of right now, I don't think we have conclusive evidence regarding its role.
Okay, thank you. Other question from Jennifer Rickman. At what point do you recommend bariatric intervention in non-HIV and non-Hep B, Hep C?
Well, I think this is always a challenging question. Really, when one looks at effective strategies for NASH, there's no question that weight loss is beneficial. And obviously, strategies to lose weight that rely on non-surgical interventions would be preferable, but we've all clearly documented the failure to achieve that in many individuals. So that brings us to the surgery option. I focused on that in this population of people with HIV because it is only now being recognized as a strategy people are using, and we're starting to see publications, including the study that I presented. We don't have good information about antiretroviral drug absorption, and that needs to be addressed in future studies. What is the impact? Obviously, we can measure the viral load, but in general, I think when we're talking about individuals with a very high BMI and morbid obesity who have failed aggressive attempts at non-surgical management and who have comorbid conditions, including NASH, type 2 diabetes, it is a time we should be discussing that and at least trying to empower our patients to get information about the pros and cons, keeping in mind that this approach is not without potential complications. And I didn't highlight this in the study presentation, but the review in the patients with HIV suggested there may be more stricture formation following surgery in that population. So again, it's not a panacea for the problem. And then I would say, backing up, I think we need to be cognizant that this weight gain is not, that we're seeing in the HIV patients is not without potential consequences.
Okay. Then more related to new fatty liver drugs that you ended your presentation with, and that they might be coming in the future. With that in mind, are there any unique aspects of HIV that would exclude patients with comorbid NAFLD of being eligible for those new fatty liver drugs in 2020?
Well, that's a great question again. It's funny, but when we started hepatitis C drug development, there was the idea this was a special population. And then it became clear that it wasn't, that we could actually just start to merge these patients into the same studies. That approach has not been taken. So I think we'll be, hopefully in the near future, being faced with the challenge of trying to integrate these new medications for NASH into our clinical practice. It's important to recognize we don't know which ones will succeed, but for example, centrocriviroc, the CCR2, CCR5 drug, is also effective against HIV and has been studied extensively. So I would feel comfortable with that particular agent. But I think we're going to have to lean on our clinical pharmacology colleagues to ensure that there are no drug interactions, and I do believe we'll need to see studies showing the demonstrable safety, efficacy, and tolerability in this population as well.